there. And then
Right.
creatinine of 0.6 milligrams per deciliter.
0.6?
0.6 milligrams per deciliter. And then blood urea nitrogen, or BUN, of 20 milligrams per deciliter. Okay, so let's war game this question before we go for the answers. So what are we actually looking for with this patient when they give these values? We're looking for normal values or abnormal values?
Abnormal.
Let's talk about the normal values first so we can clearly identify those, and then we'll know what the answers are, correct?
Yes.
Okay, so in hematocrit, what is the correct, because we had a really good discussion about these values yesterday with Tanner, Sandra, and Addison, so these should be fairly easy for us. And then, Adriana, I'm just guessing that you are reviewing these, but if you don't,
Yeah.
look at them right now. You have a pretty good handle on these two. So hematocrit of 30%, is that a normal value or is that abnormal?
That's low, actually.
Anybody else care to differ, or do you agree?
I think normal is 37 to 50, right?
Yep,
Correct.
37 to 50, so it is a little low, correct?
Yeah.
So we know hematocrit for that patient is low. Why would their hematocrit actually be low? Why would it be below that value?
They're bleeding?
There's a bleed going on somewhere.
Could be.
Okay, perfect. That's excellent. That's excellent. So Sandra and Tanner and everybody, that's the second order thinking. We know it's low, and then our mind should start to think, hey, what's going on with why that's low? And you hit it right on the head, Sandra. She's probably bleeding. Okay, perfect. Okay, albumin of 3.0 grams per deciliter. Is that something that we've learned yet? Protein levels?
I
think it
Don't-
is, isn't it?
I thought they told us this once, but it wasn't something they made us memorize.
yeah, it's not one that we are required to memorize. So.
So I will give you this one so that you guys will know what it is. The normal albumin level is 3.5 to 5 grams per deciliter. So is this patient within that or outside of that?
That is outside. That's under.
They're a little low, right? Their protein level's a little low. So that's
Little low.
abnormal. Again, now do we know anything that would make a protein level be low?
Yeah, I'm sure
They
we
could
do.
be having proteinuria, maybe.
They could, well, they're low protein, yeah. So they're either pissing it off, or
Bleeding.
the other organ that we talked about
The
yesterday,
liver might-
the liver, right? If the liver,
Liver might
is
not be.
there you go,
synthesized.
perfect. Liver has a huge function with protein digestion and protein synthesis. Okay, so either or, they're either pissing it off, or they're not digesting it to the liver. Okay, excellent. Let's keep going. So those two are abnormal. What about calcium level? A calcium level of 10, is that normal or is that abnormal?
That's normal, right?
That's normal
Yeah,
value, right?
8.5 to 10.5.
Yep, 8.5 to 10.5, they're normal. Okay, hemoglobin of 8.
That is low.
It's really low.
So
Okay.
also a bleed could be a concern.
So if their hemoglobin and their hematocrit's low, what do we definitely know what's going on now?
Bleeding,
They are definitely
Or-
bleeding somewhere.
some type of bleeding.
Yep, they're either internally or externally bleeding, but there should be a response on our part as nurses. But hemoglobin and hematocrit are both low. What about creatine level of 0.6?
That
This is a value they asked us to learn.
is it.
I think it is. Is everybody getting the blank stare? Okay, so normal creatinine levels are 0.5 to 1.2.
0.5 to 1.2.
So is that normal?
Yep.
That is
That would
normal.
be a normal value. And if they haven't required us to learn these, guess what? We're getting ahead now.
Yeah,
Now
we have to learn them anyway.
And we see creatine levels, it's going to be review. It's not going to be new. You guys will have heard it with us in our group. And isn't that what our study group's supposed to be about? We're trying to get ahead. Okay, so like for Tanner, he's heading into practicals next week. They're going to expect that you know some of this, right?
Yes, sir.
Okay,
Yep.
so let's get you spun up so you can come back and tell us how awesome practicals are, and you can be the shit.
Alrighty.
Okay. And then the last one is blood urea nitrogen levels are 20.
That's
So is that normal?
normal.
That's normal. So
Right at the edge.
What's the acronym?
10 buns, 20. No, 10. Yeah, 10.
10 buns gives us
20 buns.
butt cheeks.
Yeah, 20 butt cheeks.
So that is a normal value, right? They're at the very extreme, but it's normal.
Right.
Okay, so
But
which
right
ones
at the
which ones
edge,
are the normal ones? Which ones are the ones we're concerned about? Throw them out there.
hematocrit and the hemoglobin, the albumin too, because
Okay.
that's going to cause also hypovolemia.
Okay, so the correct answers, ladies and gentlemen, is 1, 2, and 4. You guys got them. Okay, we good?
Yep.
We're good.
I'm done. It's Adriana. I'm now.
All right.
I'm now the Padawan learner, and you are taking charge. And I'm at your mercy now as well with everybody else.
So we can start right at the blood gas values, which I think everybody's okay with, right? Now we have a pH value of 7.35 to 7.45.
Yep.
Anything below 7.35 is going to be acidosis. Anything above 7.45 is going to be alkalosis. Then we have our PCO2 of 35 to 45. And this, since CO2 is an acid, is the reverse. Anything under 35 is going to lead to alkalosis, while anything over 45 is leading to acidosis. And then the HCO3, 22 to 26, and that's our weak base. So that's also anything below 22 will be acidosis, above 26 alkalosis.
Okay.
And our the pressure, right, the PaO2, 80 to 100, that's the tissue oxygen perfusion, and it's tested with a pulse oximeter.
Okay, so PaO2 is actually arterial blood. It's blood.
PaO2, PaO2 is the arterial blood.
SaO2, which is blood saturation of oxygen in the tissues.
Thank you. Okay, so this is.
Follow that. Are you guys with us on that one?
Yeah, will you tell me one more time PCO2 is a...
PCO2 is an acid.
It's
So
an acid.
partial pressure of carbon dioxide is PCO2. HCO3 was, what's the name of HCO3? What's the street name of that?
That's the bicarbonate.
That's bicarbonate, right? Okay. And then PaO2 is what? It's if it's PA in front of it, what does that mean? Partial pressure. Whenever you hear the term partial pressure, it means you're pulling the values from venous or arterial blood. You're pulling it from a vein or artery. Okay, but SaO2 is called pulse oximetry or blood saturation in the tissues. And then Adriana, will you explain to us how again you get oxygen saturation in the tissues, how that's taken?
Oxygen saturation in the tissues is taken with the pulse oximeter, right?
Yeah. So Addison, have you done that at work yet? Done pulse ox? Addison, she's still
I'm
with
here.
us? Are you
Yeah,
still?
I have.
Have you taken pulse ox at the hospital?
Yes.
So how do you do
Put it on
that?
their finger.
You tell us. So you do it how?
You just put it on their finger.
Yeah, it's a little probe, right? A little black box. You just stick it on their finger, and then it reads back what their oxygen saturation in their blood is. Does anybody know how that machine works?
I don't know how it works.
Okay, the way that works, it actually uses an infrared scanner, and it sends an infrared beam through their skin. And because of resistance, water and different things has some resistance. It just reads the resistance of those things. What disease process have we learned in the past that would defeat pulse oximetry?
That's the one where the hands get really white and cold and they don't have any oxygen.
Like thrombobangitis was one of them. And the other one was anything that causes peripheral blood to not reach the digits is going to cause.
Say that name again. What was the name?
It's called thrombobangitis is one of them, and the other one is called.
I can't remember that one.
Yeah, I'm gonna look it up right now. One of the diseases I kept calling it thrombobangitis just to be funny.
Yeah,
but it's actually pronounced thrombobangitis. I was just being funny again, trying to find some humor in nursing, so I was calling it thrombobangitis. Because I just wanted to walk into somebody's room and just say, "I'm sorry, but you have thrombobangitis."
Yeah.
Okay.
Ooh, blood flow.
I thought it was in the blood stuff.
Yeah, I thought so too, but I can't find it. I think it was actually in the interactive
yeah, I can't remember
thing
the hell
that they talked about it.
I'm losing it. Oh, here it is. It's in Unit 5 cardiac. So Raynaud's disease is the one that just has low blood that causes you have white blotchy patches in your fingers. And then
Right.
thrombobangitis is where you physically have cell death and necrosis, and a lot of times you have to amputate those digits.
And the thrombobangitis or Berger's disease is more prominent on young males
Yep.
that smoke,
It's
right?
a lot.
And the Raynaud's is in females.
It's more common in women's. Okay. Are
Right.
we good? Can we keep moving? Keep moving.
Okay, next one. Indicators of hypoxia. I just put the early rat is late to bed. So we
Okay.
know the early ones are restlessness, anxiety, and tachypnea, tachycardia. And the late ones are your bradycardia, extreme restlessness, and dyspnea, severe dyspnea, like having a really hard time breathing. So, and then we also have the indicators of severe hypoxia, which are the tripod position, the use of accessory muscles, and cyanosis.
What's the tripod position?
Okay, you're gonna look at this, right? When they sit like this or put their hands on their knees and breathe, that's the tripod position. Or even sitting down, they still bring their body forward to try to breathe and try to get oxygen. And they're using the accessory muscles, so you can see that they literally, like, they get these things that just sink in because they're forcefully trying to draw breath in. So that's one of the symptoms, like the accessory muscles, tripod position, and cyanosis. So they're starting to turn blue, lack of oxygen. All right, then ventilation perfusion. Do we know what that refers to? Ventilation is airflow. Perfusion is blood flow. And we're talking about lungs here. So ventilation is the air being able to reach all of the alveoli. And the perfusion is the blood being able to run through all the tissues in the lung. So if we have a ventilation problem, we're going to have a block or an obstruction in the airways. So be it the trachea or bronchi, bronchioles, that's going to be a ventilation problem. And then if we have like an emboli or something that's preventing blood flow to tissues in the lung, then we have a perfusion problem. So those are the two things that
Okay, you guys ready for something? So can you see this? Can you see my thing on my screen?
Oh, yeah.
There's a balance again, right? So we have a balance, which ventilation's on one side and perfusion's on the other side. So what happens if I have elevated perfusion? My perfusion is higher than if my ventilations are higher than my perfusion, my oxygen getting to the blood, what's going to happen to my scale if ventilations goes up?
It's going to be imbalanced, right?
It's going to be out of balance, right? So my ventilations is going to get heavier, and it's going to force my perfusion up, right? They're not going to be in balance anymore, and we want them to be balanced. So what would I have to do? What can I do to the lungs to make ventilations go down, and what can I do to the blood vessels to make perfusion go up? What can I do?
Vasodilation for the blood vessels and constriction for the bronchi. Or
there you go. That's perfect. So what I'm going to do is I'm going to affect the blood vessels by dilating the blood vessels to allow more oxygen or more blood cells to move through that same vasculature. Okay. And then for ventilation, what would I do to ventilations to slow ventilations down? So if I've dilated the blood vessels, something else has to constrict. So I'm going to constrict on the ventilation side, the bronchioles. I'm going to make those smaller and make it harder to breathe, bring air and oxygen in and push carbon dioxide out. And then I'm going to dilate the blood vessels to make it easier for blood to move through those vessels. Does that make sense? So over here I've constricted bronchioles, and over here I've dilated my arteries and made it easier for the blood to move. Now, I'm going to erase this. I'm going to do a different thing. This time, Adriana, you cannot answer. Someone else has to answer this time. Okay? So everybody else, you guys ready? Okay, here's my scale again. This time, my perfusion is actually too high. The blood is taking oxygen into it and releasing carbon dioxide faster than the lungs can bring it in. Okay, so this time we're opposite. So what can I do to the blood vessels to slow that process down?
Constrict the blood vessels.
Yes, thank you, Tanner. You got it. So I constrict the blood vessel side, which makes the blood harder to move. Right, it slows it down and gives the lungs more time to bring in air to keep and to get this back in balance. So if those are constricted, what happens on the lung side? Remember how I said before, if something constricts, something has to do what?
Dilate.
Dilate. So what's dilating on this side?
The bronchioles.
So the bronchioles are dilating now, making air easier to get into the lungs, and I've constricted the blood vessels to make oxygen or blood, harder to move through the veins and arteries.
Right. Okay.
That's the relationship between ventilation, perfusion, abnormalities, whatever they are. So what if I'm getting choked? If someone's physically choking me or I've got an airway obstruction, what's going to happen on my ventilation side?
That's going to be constricted.
It's going to be harder to breathe, right? Which is going to cause perfusion. It's going to cause ventilations to go down, right? Ventilations are now out of balance. They're going down. And what's going to happen on the perfusion side? It's going to go up. You're going to want more oxygen in your blood than you can get. So what's the body going to do to counteract that, to make it easier to breathe, and it's going to slow the oxygen on the blood side down?
Oh, it's going, well, let somebody else answer.
Adriana, so don't answer because you know. Sandra, what's going on? You tell me. You're being kind of quiet, and you're usually pretty loud, so come on.
I know. I'm having a hard time concentrating. I'm like hurting. I'm really hurting.
Your foot's hurting you?
All right, it's time to
rest.
Back down to why it's hurting.
Elevation medication. That's your treatment for a sprained ankle. I'm sorry you're not feeling well, by the way.
No, sorry I'm not contributing.
No, you're okay. So Tanner, I'm physically getting choked. My ventilations are down and my perfusion's gone up. What is my body going to do to get that back in balance?
So it's harder to breathe. Your blood vessels would dilate,
and your bronchioles will what?
Well, they're already constricted.
The bronchioles would dilate. The bronchioles would dilate.
Yeah. Again, I'm using this extreme example of you're getting choked, but again, I use that hey, the airway's occluded or obstructed, right? I've got limited airway. So again, just know that the perfusion side, you're going to have your blood vessels dilating, and on the respiratory side or the lung side, you're going to, again, you've already got an occlusion probably in the esophagus somewhere, but the body's nervous response is to also dilate, to
get as
constrict.
much oxygen as you can from whatever is available, right?
Yes. So just look at what's going on. So what happens if someone's bleeding? What would happen to this system if someone was actually bleeding? Which side of the system is it going to affect if someone's bleeding?
So that's
perfusion.
And that's perfusion. So is perfusion going to be going up or going down if they're bleeding out?
It's going down.
Yeah, it's going down, right? They're bleeding out. So that's the part that's out of balance. They're physically bleeding out. So obviously the best thing to do is to stop the bleeding. But what's the body going to do whether we do anything or not? If they're bleeding out and that starts to drop, what's going to happen? So they're deficient. They're deficient in perfusion. Perfusion's low.
So you're gonna
tachypnic.
Yeah.
They're gonna be tachypnic. They're gonna try to breathe. Like the body tries to compensate by getting more oxygen in. And even though there's not enough red blood cells to carry it, the body doesn't really know. It just wants to get more oxygen in. So there's going to be tachypnea.
So you're going to breathe harder and you're going to want to bleed less. So bronchioles are going to open up and dilate. And on the arterial side, the arterioles are going to constrict. Okay. So let's not beat that to death. I just wanted to make sure, because that is not a difficult concept when you start working with it. But right now, it's hard to wrap your head around, hey, what the hell is going on? But once you kind of work with a little scale and say, okay, they have pulmonary edema, right? They have fluid in their lungs. Now, their respiratory side, their ventilation side is low. They're not able to ventilate. what's going to happen? Bronchioles are going to dilate to let more air in, and then their blood vessels are going to constrict to slow the air down, to slow the blood down, so that there's going to be more opportunities for the air that's getting in to actually move over and get into the blood.
Yeah.
Okay, so either side. So if they're bleeding, it's perfusion side that's going to be low. If there's any kind of occlusion or process in the ventilation side that's slowing it down or speeding it up, it's going to change it.
Right.
And so the only things that can happen are dilate and constrict on either side, and it's going to be bronchioles or arterioles. That's it.
And the thing that Megan reminded us was, if we are having a problem trying to remember what is what, if you think of air vents, it's ventilation, right? Air vents, it goes with the air. So it's going to be air movement, air flow in the lungs on ventilation, and blood flow on perfusion. That's just the thing to remember. Let's go on to the next thing.
I'm sorry, guys. I beat that to death. I'm sorry.
No, it's all right. We just have a lot to cover. So atelectasis, we'll go quickly over it. Basically, it is the collapse or the alveoli are prevented from inflating. And it can be due to a number of things. It could be either there is no surfactant in the alveoli, so they collapse and they stick together and they cannot expand. Or it could be a problem with a tissue not being able to recoil as it did before for different types of diseases such as COPD, asthma, etc. Or it could be a compression atelectasis, which is in either hemothorax or pneumothorax, or even like a cancerous mass that is physically pressing on the lungs and preventing the alveoli from expanding. So that's just the main thing. Atelectasis is the alveoli unable to expand. They're being compressed or they're falling shut for some reason. Any questions on that? We're good. The pneumothorax, it's air entering the pleural space, and that's the space between the chest and the lung itself in the pleura. Those two, the visceral and parietal parts of the sac that holds the lungs. So this is basically the lung tissue causing ruptures in the tissue itself, and the air in the lungs seeping into that space, and it builds up until it starts to compress and cause atelectasis on that lung, because it's compressing, it's not allowing the lung to expand fully to breathe. There are two types. We have our tension pneumothorax, which is the most dangerous one, and that's the one where the air does not have a way to escape. And we have an open pneumothorax, which you are able to get some of that air out. So like in a stabbing wound or a shot or anything where you have actually a way for the air to get out, then it's not as dangerous as it is when it's just an injury inside the lung, and it's the buildup of the air keeps growing and compressing the lung, and even pressing and pushing the heart and the trachea out of the way and causing problems with the heart. All right, so I think that's the main points on pneumothorax. Do you have any questions on that?
So why, everybody except for Adriana, why is a tension pneumothorax more dangerous than an open pneumothorax?
Pressure.
It's not pressure. They're both causing pressure on the lung, and they're limiting ventilation and making it so that you can't breathe. Which would be easier to see? A tension pneumothorax is what's called closed, which means that they've had an impact, and the impact and the trauma has gone inside the body and torn the lung away. But when someone walks in with a knife sticking out of their chest, which one's easier to see?
So the knife one. The diagnosing differences.
Yeah. They could be in the hospital, and we may not even know. Like, say, for instance, it's a young man who is playing football. He comes in complaining of chest pain, but he got hit in a game or in a practice. And besides that, he's 15 years old. He's probably going to compensate a long time before he's in serious trouble, right? He might have just some referred pain, but he's come in, right? And so we're checking him out and checking his blood pressure, and everything's fine. And then all of a sudden you look at his throat, and his trach is deviated over 2 inches. right? That was a tension pneumothorax. We didn't see it. And then his trachea deviated over. Now his heart's compressed. Now he's in a bad way because it's gone so long now that one lung is completely pushed over. It's totally occluded now. And now the heart's receiving pressure and the trachea has been shifted.
And the vessels are receiving all kinds of stress. So they could be tears in the vessels as well.
You could actually have an aortic tear at that point because the heart's been shifted so much. You can tear the aorta. So again,
we think
yeah.
Tension pneumothorax and tie it to tracheal deviation. So tension and tracheal deviation. So that means it's the most dangerous one because it can really cause major problems, especially because it starts pressing on the heart as well. So you're going to have heart function issues and it could cause death. I guess we don't need to know how to treat it or anything like that, right? We've heard about how they have to pop, like they have to stick something inside and let the air out. But I think we don't need to know that. All right, pleurisy. Pleurisy is the inflammation of the pleura. So this is, once again, the sac that is surrounding the lungs. And what happens in pleurisy is that these normally smooth walls get rough and they start rubbing against each other, and if there's inflammation and it's very painful to breathe. And if you hear them, if you do auscultation, you hear the lung sounds, it's going to do that what is friction rub sound.
Scratchy.
It sounds like every time you breathe, the lungs are rubbing. Not the lungs, but it's the pleura that's rubbing and causing that sound. So painful breathing and coughing, chest pain, and the friction rub on lung auscultation. That's the main points on that one. Then pulmonary embolism, I guess that's pretty simple. The arteries of the lung become blocked by a blood clot, which causes a perfusion mismatch, which is a blood flow problem in your ventilation perfusion. And then we have, without the blood flow to a part of the lung, the tissue will die due to ischemia, lack of oxygen, to that special area or that specific area. And most of the times, these embolisms will come from DVTs. So usually it's going to be, or atrial fibrillation is another one where you've had fibrillation and the blood in the heart has been sort of stagnant for a bit and it's caused some clotting. And then when it passes on to the lungs, it could also cause an embolism.
Yay, embolism. How much fun is that?
Yeah. All right. Any questions on that? I think we're all good. Right. Now, pleural effusion, a buildup of fluid between the reefs and the lungs. Now, this is fluid between the lung and the pleural space. So this one you can actually draw out with, what is it called? Thoracentesis, I believe is the name.
Yep,
you can actually put a needle inside and aspirate that liquid out. So that's pleural effusion is the buildup. And it can be either serous, which is just like liquid pus. So it's purulent, it has white blood cells and all kinds of debris. It could be lymph fluid, could be blood, which is a hemothorax. And of course, it can cause atelectasis because the hemothorax is going to be pressing on those alveoli, preventing them from expanding. So atelectasis, there it is again. Then the next one, important too, pleural edema. That's in the interstitial space. So now we're having liquid, water, pus, blood, whatever it is, in the actual interstitial space, either inside the alveoli or in the spaces between the alveoli. That cannot be aspirated. That would be really hard, right? It's like trying to get the water out of grapes. If you were trying to get that, right? Instead of just going to one space and removing all the liquid, you would have to like go one by one. Can you imagine? That would be crazy. So yeah, pleural edema is not, you cannot aspirate. You cannot remove it. Any questions? Oh, and the causes for that, usually the systemic inflammatory response, or SIRS, also known as our ARDS, or what is that? Adult respiratory distress syndrome.
Respiratory distress syndrome.
Sepsis is another one. Lung damage that causes inflammation. And those are the main points that I wrote down on that.
You guys know what sepsis is?
Yes. Like systemic.
It's a systemic shock, right?
Yeah.
And it's due to infection, not to blood. You're losing blood because the infection is causing your blood vessel walls to open up.
Capillary, what do they call it?
It's your capillary permeability.
Yeah, capillary permeability
is lost, and so it opens up and just lets the fluid from your blood vessels open up.
It just seeps
but
out.
It's systemic. It's in your whole body. It causes that to happen.
Mm-hmm. Any
Okay.
questions on that?
Nope.
Keep going.
Good. The adult respiratory distress syndrome, or SIRS, also, it's that one starts with an acute lung injury of some type. It can be either infection, sepsis, trauma, hypoxic event, aspiration of gastric juices or vomit, pulmonary embolism, blood transfusion reaction. I mean, there's so many things that could cause it, but basically it's all for the same, it ends up in the same thing, that the severe inflammation is going to release a ton of chemical mediators and clotting factors, vasodilating agents, and the response in the lungs is just too much. And so the lungs stop producing surfactant, and that causes them to collapse too. Without the surfactant, the lungs collapse and stick together, the alveoli, and they cannot open again. So there's another form of atelectasis. And then there's six steps that just keep getting from bad to worse, right? So we start with respiratory alkalosis. Because of the injury to the lungs, the body tries to compensate with tachypnea. Tachypnea is the word, right? So the body starts to compensate, trying to breathe faster, trying to get air in, and it causes alkalosis. Immediately after that, since the body cannot keep up with that fast pace of breathing, then you start going into respiratory acidosis, because CO2 is building up in the lungs. There's not enough oxygen, and the blood is not carrying enough oxygen. Now, the lungs start to release all these chemical factors that cause capillary dilation, or leaky capillary syndrome. And then there's the blood clotting in response to the inflammation and tissue damage, because we're starting to have tissue damage in the lungs from the acidosis. And then we get microclots, which block perfusion. So just getting from bad to worse, right? It keeps getting worse and worse. Then you have tissue death, which means cell death, which means potassium spilling out, causing more acidosis, and just making things worse. And finally, we end up with respiratory failure.
And you die.
Yeah, decreased cardiac output, because the heart cannot handle it anymore, and the hypotension, and eventually death.
Okay, so before we jump off on here, how many times with our acid-base cycle did this change? So we started with what, Adriana? What did we start with? What was the
respiratory alkalosis?
We started with respiratory alkalosis, right? And that was because we were blowing off too much CO2, which is an acid. So remember our balance again? This is more of a review for us. Where the hell did I put my stupid? Oh shit! Sorry, I'm pressing.
Balance.
Hey, listen. So remember the balance, because again, I like to use these visual cues to help out. Okay. So we had acid and we had base on our balance, right?
Right.
So this condition started us to go into what first?
Base.
We went to respiratory alkalosis because acid was being blown off as CO2. Okay, so if acid's being blown off and going up, what's happening on the basic side? It's going down.
Oxygen,
right?
yeah.
Now, what happens to cause us? So, what was the next step? What happens next to this balance? What's happening now?
The next step is that the body cannot continue with that pace of breathing, so it stops, and then you start getting a buildup of CO2.
So CO2 starts to be getting held onto, which causes the acid side to get larger again, and it drives it back down. But not only does it drive it back down, now our respiratory system is tired.
Acidosis.
So we start to go into a
acidosis.
If acid starts getting heavier in the balance, then what's going to happen to the basic side? It's going to shoot up, right? So now we're in a acidic condition. But now it's not respiration that's causing that. It's what's causing it. It's metabolic. Our bicarb and the other chemicals are causing us. So on this side, when we started, it was respiratory that was causing it. We were breathing off too much. Now the metabolic properties in our body start to kick in. In addition, muscles in my lungs are just like muscles in my legs. If I run too hard, I eventually stop running, right? My legs get tired and I stop running. Your respiratory system's exactly the same. My diaphragm's gotten tired. I'm not breathing as hard, so now I'm not blowing CO2 off. And the metabolic processes are working, and so now it's driven me into a metabolic acid condition. I'm in now metabolic acidosis. And then in stage 2, or in the intermediate stage, stage 2, pulmonary edema happens. What's pulmonary edema? What happens in pulmonary edema?
So we start having the leaky capillary syndrome is going to start pushing liquid into your lung intrapleural, interstitial space.
Yeah. So the easy way of saying that is my alveoli now are full of fluid. They're full of water, right? Or something, blood, whatever. So we talked yesterday, you guys, about what happens to the respiratory process when our alveoli start filling with fluid. Is that good or bad?
No gas exchange.
No gas exchange didn't happen. So now, in addition to metabolic situation of acidosis, now I physically block the body's way of blowing off CO2 and getting oxygen in. I physically blocked it by filling the alveoli with fluid. Okay? So that's also, now I've got two processes working to drive me even more into an acid condition.
More metabolic acidosis.
Yeah, so now we've got two processes. In addition to metabolic acidosis, I've also blocked the respiratory process that I would normally use to bring me back to balance. It's physically blocked now. I've shut that door. That's intermediate step. Oh, now, because I've damaged all my alveoli, now my body's gone into stress, and it's saying, hey, I got some serious shit going on. So my body starts to push out those cytokines and those immunoglobulins, because that's stress. The body's under stress. And so we start to have clotting going on. Oh, now I've physically started clotting the blood vessels coming into the lungs. So now I blocked the respiratory process, and now I blocked the perfusion process to get in there, to even move blood in there to the alveoli that are working. So are you seeing the death spiral? How this is
from bad to worse.
Yeah, bad to worse again, to finally, now I blocked the blood vessels and I blocked the alveoli. Both the perfusion and the respiratory process have both been blocked. They've both been shut off. How difficult do you think it is as nurses and doctors and care providers to get somebody out of this?
Very difficult.
Okay. Is that a little bit clearer what's going on with that? They start in alkalosis, and immediately the body starts to compensate, but it overcompensates, and it starts shutting processes down. If we don't intervene very quickly, these people die.
To the tune of 40%, as a matter of fact.
So
yeah, and then the 60. Yeah, the final thing is that the 60% who do survive are going to survive with major irreparable damage to their lungs, and not just that, but also cognitive and psychological problems. Cognitive due to the lack of oxygen in the brain, so they have hypoxia to the brain, and also psychological. One of the things that Megan said was PTSD. You survived a horrible event, and then you have that, that trauma for the rest of your life.
So Sandra, can you re-explain that to us? What's going on with that? Those steps?
So you're breathing. Why do you start breathing too fast, though?
Because you've had impact, you've had trauma to your lungs.
Some
Okay,
type
so
of injury that's preventing oxygen from entering your lungs.
Yep, some kind of trauma, whatever it is, whether it's an infection, impact, cancer, right? Any of those processes can cause us to get an acute trauma to our lungs. And when you get acute trauma, you want to breathe harder. Oh my gosh, I'm in trouble, right? It could be psychological, right? When you go to the fun house or the scary place, you breathe harder, right? You experience it as a trauma, and your body starts to bring in oxygen in order to deal with that trauma. Okay, so
you
keep
start
going.
breathing faster, and this leads to respiratory alkalosis because you're breathing off carbon dioxide.
Carbon dioxide is what, by definition? Is it acidic or basic?
Yeah, it's an acid.
So when you blow acid off,
yeah, you're removing acid from your body by hyperventilating.
there you go. Okay, keep going. What's step 2?
And then you immediately try to compensate that. Well, no, that's not what's happening. It's just that your lungs stop being able to function as well and can't maintain that rate of breathing. And so then you have a CO2 buildup, which is respiratory acidosis.
So yeah, so you've removed the respiratory alkalosis process. You're not breathing as hard, but what's the rest of the body doing to bring that alkalosis condition down? When it's not respiratory, it has to by definition be what?
Metabolic.
So metabolic. So bicarb. Your kidneys start to kick in. Your liver and other organ systems start to kick in to try to bring that alkalosis condition back up to a normal condition. But it's exaggerated. Why? Why is it exaggerated? Because the breathing has stopped, and now those metabolic processes have kicked in. It's a double whammy. So your breathing, which would normally regulate that acid response, has stopped as well. So the breathing has stopped, and the metabolic response has kicked in, and so it's a double whammy. It's like wham, everything should just shift.
Plus, you have other things that are adding to the acidosis. So you have your body, the cells move from aerobic to anaerobic metabolism, which produces lactate, which is an acid. And you have cells dying and releasing their
Potassium.
Their acid. What is it, like potassium or something?
Everybody give me a hallelujah. Hallelujah.
Hallelujah. It's the potassium.
Hallelujah.
I think Sandra's got a pretty strong understanding of this.
But that's only step 2, and then what are
You're there. So step 2, you stop the blood, you stop the flow of oxygen in the carbon dioxide with respiration. Now you've got this elevated metabolic response. So what's happening to the blood? Is the blood moving faster or blood moving slower?
Slower.
The blood slows down, and when the blood slows down, it gets moving too slow. Where does that blood and the plasma components in that blood want to settle?
Oh.
They slow down. They want to go somewhere. They don't want to stay in the blood vessels. They like to be moving at a certain speed. And when that speed slows down, they're looking for the freeway off-ramp. They're looking for a place that's not as concentrated. They're looking for open spaces, that interstitial space. And, hello, I've got all these alveoli sacs that are full of air. There's no resistance getting into those. It's like, hell, here's an open air space. Let's just flow into there. There's no resistance to get into there. So that those components flow into the alveoli, and now what do you have going on?
So then you have you've got edema going on.
Pulmonary edema is happening. Does that make it easier or harder to breathe?
Harder.
It's harder to breathe again. So now now our lungs were just tired, muscularly tired. Now we've just thrown some fluid in there.
Gotcha.
So when we're able to breathe, when our muscles are relaxed and they're able to move again, now they're fighting an uphill battle through fluid to breathe.
Yeah, it makes it really difficult for the gas exchange.
Plus, you have damaged, epithelial linings at this point, and so you're getting some damage. You've got liquid oozing from that too.
So now your body's in a state of bleeding trauma. What does it want to do now when it's bleeding? When your body's
so now it clots.
Hallelujah.
Okay.
Everybody give me a hallelujah.
Hallelujah.
Tanner, I can see the look on your face in the camera. It's like literally the light bulb just came on. I mean, is that a fair assessment? I'm seeing your little face, and I'm like, you're like, holy shit, that's how it works. The processes that we've learned individually tie together.
Yeah.
And they make sense when you learn them and you go over them. They make sense. Okay, so now we've got this blood clotting going on. Where is the blood clotting happening?
In the lungs,
In the
which
lungs,
is leading to more hypoxia. So everything that is happening and each step is leading to worsening hypoxia.
Yep, worsening conditions.
All
And then
right.
the last step is
You fail. It fails.
the renal process fails, or the respiratory process fails, and you die. And if you don't die, you're a human vegetable, and you're on a
Almost.
Awesome.
It's got to be pretty bad anyway.
To quote the immortal Dr. Leonard McCoy from Star Trek, it's life, Jim, but not as we know it. Okay, sorry, Adrana. That's a really complex process.
It
I
is.
want to make sure that everybody got it. And that
It
it
is a good
builds on
one.
the things that we've already learned, that we talked about respiratory and metabolic acidosis and alkalosis, and those are not standalone things. They're important for this stuff. They make sense when you start using them to diagnose other crap.
Yeah, I can see that we're starting. Sorry.
Okay, we good? Everybody, did I just beat that to shit for everybody, and now we're ready to move on?
Well, I just want to know, that last stage, is that the same thing as respiratory shock?
Yeah, respiratory shock would be, well, so your respiratory shock is meaning that your respiratory system is not working, and we are in a condition now that we cannot fix it. If you can't fix shock, any kind of shock, hypovolemic, septic, neurologic, renal, respiratory, if they're in the final stages of uncompensated shock with any of these systems, what are they heading to?
Death.
Yeah.
They're heading to the grave. There's really
just
nothing that we can do.
If I may, it's just such severe hypoxia that now you have a lot of organs failing because they are all lacking oxygen.
Okay.
So does that answer your question? So yes,
sir.
Tanner, that is going to lead to respiratory shock. Respiratory shock is going to be right before they do what? They go meet their maker.
That's right.
They're
All
gonna
right.
be in shock for long enough for you to say they're in shock, and then you're going to be calling their next of kin.
Yes. All right, on to the next thing.
I'm sorry, that was really more, but I'm sorry.
Right, so we have COPD now. So any type of disease that causes obstruction of the respiratory system. So any type of obstructive disease that includes asthma, chronic bronchitis, cystic fibrosis, emphysema. Those are all COPD. They're under the umbrella of COPD. And some of the things, things to remember with that is that they will be easily fatigued, frequent respiratory infections due to that obstruction. It's just like you can hold a lot of bad stuff in your lungs if you're obstructed. If you have too much mucus or whatever it is that's obstructing your lungs, you're going to have a lot of frequent upper respiratory infections. You're going to use accessory muscles to breathe. You're going to be orthopneic, meaning that depending on the position you're in, you're going to have a difficult time breathing. They have usually a thin appearance, wheezing, pursed lip breathing, the barrel chest, that the chest expands because it's holding on to so much CO2 that the lungs try to get bigger and open wider to try to get some oxygen in with that CO2 that's trapped in there. So that causes the barrel chest appearance. Bronchitis, digital clubbing. Has anybody seen that digital clubbing thing? It looks horrible. Look it up on Google, digital clubbing. It looks really bad. And another thing to remember is that patients with COPD is they live with elevated CO2 levels. So their CO2 level is no longer what drives their breathing. Their respiratory drive is actually triggered by low oxygen, which is the reverse of normal people. For normal people, a high level of CO2 triggers the respiratory drive, in people with obstructive disease that, live with permanently high CO2 levels, it switches. So it's a low oxygen that will drive them to breathe. So the implication with that is if you give these patients too much oxygen, you shut down their respiratory drive. There you go.
That's digital clubbing.
Digital clubbing.
Can you guys see the digital
horrible.
clubbing? Digital clubbing.
Yep. So those are the important things to remember with COPD. Like anybody that has COPD lives with permanent high CO2 levels, and therefore it's oxygen that drives them to breathe. Lack of oxygen triggers their respiratory drive. So we don't want to give them too much oxygen because we'll shut down their respiratory drive. Then in those we have asthma, which I think pretty much everybody's familiar with asthma, what it does, how it happens. It's an inflammatory disorder. It's triggered by either pollutants or any type of airborne irritants. And the body responds, remember the acid response? This one is the first one. The anaphylactic shock, is that the one that, is that what they call it? So it's the one that shuts down your breathing immediately because it tries to protect the lungs from receiving any more of the pollutants or whatever irritant it's causing them the inflammation. So that one is the airways get swollen and very sensitive. It has a familial tendency, so it could be inherited. So if somebody in the family has it, most likely somebody else in the family will too.
Or if you just live in Utah. If you live in Salt Lake County, you're just going to get asthma.
Yeah, right. Hypoxemia, so low oxygen in blood, coughing, increased mucus, shortness of breath, wheezing, prolonged expiration. So they breathe short and then they expire a lot longer than they inhale. Increased CO2 retention because of the lungs being constricted and not able to release. There's chest
if
tightness.
they're holding on to CO2, what kind of condition are they going to be in? Acidosis or alkalosis? If we're holding on to CO2, what condition are we going to be in?
I'm not answering because I know you say don't answer.
In acidosis.
So if you're holding on to CO2 and CO2 is acidic, am I driving my acid down and my base up, or am I driving acid up and my base down?
Yeah.
If I'm filling my acid can more full, what's it going to do to the balance? It's going to drive acid down. So I'm going to be in an acidic condition. Okay.
Right.
Okay, we're good. I'm done.
All right. And then we have retractions. Once again, retractions is that when they use the accessory muscles to breathe, and you can see like in their neck and this area right here, you can literally see it sink in as they're forcing breath into their lungs. And status asthmaticus is life-threatening. So we want to get them, the normal treatment that they use, like whether they're inhaler or whatever is not working within 30 minutes, you have to get them to the hospital. You have to make sure that they get treated so you can prevent death. Right there. Okay, triggers, hypersensitivity, upper respiratory infections, exercise, air pollutants, respiratory infections, and GERD, of all things. I didn't know that, but I guess it makes sense.
I'm gonna jump in here again. So on acid, 1, 2, 3, 4, what response is this? Which one of those would this be? If you were asked, hey, this person's got asthma, what kind of hypersensitivity do they have? Was it be A1, C2, I3, or D4? What kind of hypersensitivity would this be?
A1, wouldn't it?
It's going to be A1, anaphylactic. Yep. Are we all good with that? Does anybody have any questions when I asked that?
We're good.
Sandra, Addison, you guys still awake?
Yeah.
Yep.
Okay. I'm done again.
Okie doke. Because there's so many of them. Bronchitis, that's inflammation of the bronchial passages. It just shuts down the tiny airways. What type of problem is that? Ventilation or perfusion?
Bronchitis.
Mm-hmm.
This would be ventilation.
Yes, good job. All right, so acute lasts 1 to 3 weeks, and it's expected to resolve. That's one of the things with acute, right? Expected to resolve.
Mm-hmm.
In most cases, it's a viral infection. And then if we have the chronic one, is when you have at least 3 months for 2 years in a row when you experience this problem. So 3 months in a year for 2 years in a row, then you're in chronic. And with hypersecretion of thicker than normal mucus and productive cough, it increases. This was interesting because I didn't see this until today when I was writing this down. It actually increases the number of cells and the size of the cells that produce the mucus. So that's why you have more mucus.
And Adriana, when we talk about increased number and increased size, there is an actual medical term for both of those. Do you know what they are? Right. Can you remind us?
Yes, it is hyperplasia.
And hypertrophy.
And thank you, and hypertrophy. So hyperplasia is the increased number of cells, and hypertrophy is increased size.
Who just said hypertrophy?
I had to chime in because I actually knew something.
Yay! Good job. Okay, so that's what happens. That's why there's increased mucus, and then along with that, the cilia that are supposed to push that mucus up is not working either. So you can't get that mucus out, and it's really hard for them to clear their lungs. So that's another big problem with bronchitis, with the chronic bronchitis. And again, that's considered a COPD because it's of the obstructive nature. Very good. And once again, since you have all that gunk in there, you're going to have a lot of possibilities for viral and bacterial infections.
What would the name of that condition be? If that mucus flows into the lungs, collects in the alveoli, and then gets infected, what is the name of that? What is the name of that condition?
No idea.
Atelectasis?
I think you guys know what it is. It starts with a PN. The P is silent.
It's pneumonia? It's not pneumonia.
That would be pneumonia. That mucus will flow back down because it has nowhere to go. You can't force it all out. So it goes to the path of least resistance, which is down into the open air passages of the alveoli. It settles there. It gets infected, and then you get pneumonia.
With the bacteria, pneumococcal bacteria.
Yep.
So pneumonia isn't fluid in the lungs, it's just the alveoli of the lungs?
Well, no. Pneumonia is infected fluid that's sitting in the alveoli in the lung.
Okay.
Just don't confuse it with pneumothorax.
With pneumothorax, it's different than pneumothorax, but that's what pneumonia is.
Different, yeah.
Okay.
It's kind of similar in but it's not pneumothorax.
You can get pneumonia without bronchitis. I'm just saying that there's a strong association between chronic bronchitis and people getting pneumonia. That makes sense?
Yeah.
You can still get pneumonia without chronic bronchitis, but people with chronic bronchitis, if you're seeing them a lot as a nurse, wouldn't it make sense to start to check them a little bit for bacterial responses and infection in their lungs?
Yeah.
There's a chance that it's going to develop that way. Okay, I'm done again. Sorry.
No problem. Cystic fibrosis, that's an autosomal recessive gene abnormally causing multi-system disease. So this is not specific to the lungs, but the main thing to remember about this is that there's thickening of the connective tissues that leads to fibrosis, which is basically scar tissue. And it's tissue that doesn't function normally. It doesn't function the way it should. So you're going to have problems all over because obviously we have connective tissue everywhere in our bodies. The main thing with the cystic fibrosis problems with breathing is that it causes, there's this component where we have the chloride sodium reabsorption transport damaged. So we are pulling sodium out of the cells that produce this mucus, which draws the water with it, which makes the mucus really thick and sticky. So that's what cystic fibrosis, they have this horribly sticky, thick mucus that just gets stuck in the lungs and they can't get it out. And just remember that that's because of the epithelial ion transport of chloride and sodium. So the chloride or the sodium is being pulled out of the cells that produce the mucus, which draws the water with it, which makes the mucus really thick and sticky. So that's my important thing to remember on that one.
And remember, this also affects your poops.
It affects your what?
It affects poop. Makes your poop bit nasty.
Oh, I would imagine, yeah.
Stinky, stoic poop.
Okay. Oh, and especially
How much fun is that?
Mm-hmm.
Remember, if I get to say poop in a study group, it's like a good study group for me.
That's
It's a good
what I
study.
was just going to say. Like, of course, you couldn't let that opportunity go.
I could not let that fly. I had to, but that is one of the things that is associated with cystic fibrosis. It does cause nasty, sticky, stinky.
But
poop.
what's the name for that?
That is it
like,
is it meconium?
No, it's like steatorrhea or something.
Steatorrhea.
Steatorrhea, that's actually the fatty poop is
You know what?
steatorrhea.
I really hate to tell you this, but you have thrombopancreatitis with steatorrhea. I'm really.
And what you're talking about is the meconium ileum, which is actually the first poop of a newborn.
Yeah. So guess
And
what? You got meconium ileum with thrombopancreatitis with the side order of gastropoopskinitis.
Poopskinitis.
So it's terminal. I don't know what we can do for you.
Oh man.
Rectal prolapse. That sounds horrible. So yeah. So the
That just means your rectum's sticking out of your anus. It sticks out.
that just sounds bad.
Yeah, not fun.
I'm sure in practice it's not bad at all. It just sounds bad.
Yeah, well, it's like a prolapsed uterus. That just sounds awesome, doesn't it?
Oh no.
Ugh. Not at all.
Okay, keep going. Sorry.
All right. Move on to tuberculosis. It's airborne. So what do we need for protection if it's airborne?
Addison, what do we need for airborne tuberculosis?
A mask.
Which
come
side?
on.
What
You
type
know
of
the specific mask. What's the name of the mask for tuberculosis?
The 95 one.
Yep, N95 HEPA mask.
Perfect.
Addison gave her one comment every 25 minutes, so you can go back to sleep.
I'm still listening.
I know, I'm just teasing you because I know you're listening.
All right. So the tuberculosis bacteria can spread anywhere through the lymph nodes and the blood. It can go to any organ, but apparently it prefers the lungs. So it mostly just it stays in the lungs. The mycobacterium can remain in suspended animation, meaning latent for years without actually being symptomatic or contagious. But the problem is that it can become active at any time. And once it's active, you're going to have not just the infection, but you're symptomatic and you're contagious. And then it can go latent again. Once you're latent, you're not going to have symptoms. You are not contagious, but you're still infected, obviously. And another sad thing is that even latent TB can become active again. So it's something that you have to keep an eye on, I suppose. Populations at high risk are going to be underdeveloped countries with tons of people and not very clean, high-density living conditions, such as the correctional facilities, long-term care, homeless shelters, etc. Immunocompromised people are at very high risk, and as we have learned before, one of the highest causes of death for immunocompromised people are, what are they called? Starts with O.
Hold on. You said what?
Immunocompromised people, the highest cause of death are
I can't remember this.
Opportunist infections.
yes,
there it is.
opportunistic infections. That's what I was looking for.
Thank you. I honestly couldn't remember that. I could not remember that.
Yeah. Opportunistic infections are going to be the highest cause of death for immunocompromised people. So
Okay.
these are people with HIV, diabetes, kidney disease, cancers, people who use steroids. And children under 4 years old are also at very high risk. Then they do the skin test, tuberculin skin test or blood test. That can tell you whether you were exposed to the bacteria, but it will not tell you if you are active or latent. So they have to do an X-ray to see and a sputum or a sputum sample to test for whether you're active or latent if you have been exposed to tuberculosis. Another interesting thing, I was born in Mexico, so in Mexico we had the immunization against tuberculosis. So that means that anytime they do a test on me, I'm going to show up as having been exposed to the virus. So they always have to do an X-ray test for me to confirm that I'm not sick.
Interesting.
Yep. All right, on to the next one.
We've been going for about an hour and a half.
All right,
Hey,
it's up to you guys.
I'm happy to stay on, but I wanted to get this out first. So is anybody wanting to do an 8 o'clock in the morning tomorrow study group? I'm just throwing that out there. I'm willing to do it. I just want to make sure people want to do it before I volunteer it.
I'll show up.
Okay, so if anybody's going to do it, I'll open this back up at 8. Then we're going to be back at the library, which is our face-to-face tomorrow at 1 o'clock. So I know Adriana's usually there. Addison's usually there. Tanner and Sandra, you guys are totally invited. If you can't come, I'm going to blog it tomorrow. We haven't been blogging those, but I'm going to blog them. As good or bad as the blog is, I'm going to blog it. So
I'm planning on it tomorrow. If I think I should be able to walk-ish enough.
Okay. Well, don't kill yourself. But again, you're happy that we're welcome to have you come. The face-to-face ones I think are actually better than the online ones. Just volume and how much we get through and whatnot. And people just embrace the suck to better together.
Yeah. No, I want to be there. I'm gonna try.
Okay. So again, you're welcome to come. And then Sunday, again between 6 and 9 for 2 hours Sunday evening. We're at the University of Utah. I still got to get the room confirmed, which I'm working on. But again, you guys are invited. And again, if you can come, not come. Again, I'll blog that one too. Again, those are 2-hour sessions. And I just wanted to kind of get you guys that out there. So is everybody cool?
Yeah.
I work tomorrow from 6:30 to 7, but I'll be there Sunday.
Okay.
I'm to be determined all day tomorrow. My wife signed me up to help with something at our church, and so, but I've told her I need to study for this midterm, so I don't know. I'm gonna try to, but I'll see.
I love you, honey, but I think Jesus wants me to pass my exam more than move somebody's crap out of their house.
And you guys,
I'll continue for a retreat.
I'll continue to fill out as much as I can on this study guide. And even if I don't complete it, I'll send it out to you by tomorrow afternoon. So you'll have it. You'll be able to at least, review it. And hopefully I don't have any mistakes. Like I did have one mistake right at the beginning, but I think it's pretty okay.
Hey, Jenny, thanks for your work. I appreciate you.
You're
welcome.
Yeah, I got to be honest, you guys. I just get tired after an hour.
It's exhausting. Well, plus you do it how many times a day?
Even I'm starting when I miss opportunistic infection over poop. It's time to take a break.
Hey, yeah. By the way, you should need to say that as poo poo every time you.
Yeah, come on.
So you guys officially, you got me to say poo poo.
Yeah, poo poo.
Poo poo.
The study group has spoken. It will now be poo poo.
Sounds good to me.
I will now say poo poo each time.
There we go.
You really will.
Is everybody cool with logging off? You want me to leave this on? Let's keep the facilitation open, or what do you want to do?
We're good. I actually have been working all day, so I'm a little tired.
Okay, I could feel as the kind of facilitator, I also drive the train that people are just getting past comprehension, and it's just becoming minutia at that point.
Yeah.
Is that a fair representation for everyone in the study group?
Sounds good.
Yeah,
Yep.
because I was really on it earlier in the study group, but now clearly, no, I was never on today.
Whatever.
You broke your ankle today. What are you talking about?
It's a
That's
sprain.
Sandy.
It's not even a break. I'm just being a wussy.
Okay, everyone, repeat after me. Rice.
I know. I'm doing
Right.
it.
Rest, ice, compression, elevation.
Yes.
Mhm.
And then some really heavy NSAIDs, man. Just dope up.
Hope you feel better, Sandy.
Thank
Okay.
you, guys. Bye.
Addison, go have fun with your friends.
Have a good night.
Okay, have fun, guys. I'll see all of you tomorrow, or hear all of you tomorrow, or we'll just keep plugging away.
Cool beans.
Okay, later.
Bye.
See ya.